Queridos colegas y amigos, todos sean muy bienvenidos a RASH, Real Allergy Study Hall, el programa de educación médica creado en conjunto con Compedia, el Colegio Mexicano de Pediatras Especialistas en Inmunología Clínica y Alergia, y Abbott. Este programa es para profesionales de la salud que desean aprender más sobre cómo apoyar a los niños con alergias alimentarias. Las sesiones de aprendizaje cubren aspectos claves, las investigaciones más relevantes y las más recientes guías internacionales sobre el diagnóstico y el manejo nutricional. Tenemos dentro de nuestros ponentes expertos mundiales en alergias alimentarias, como el grupo de expertos de la Organización Mundial de Alergias, así como expertos latinoamericanos que compartirán su experiencia con nosotros. El programa comprende 4 sesiones que se realizarán los próximos 4 martes en este mismo horario y contará con una doble certificación por parte de Compedia y Abbott por su asistencia. Es para mí un placer acompañarlos. Soy Oscar Quintero y estoy aquí con Claudia Sánchez y somos parte del equipo de Abbott. Doctora Claudia, ¿cómo estás? Bienvenida.
Muy buenas noches, doctor Quintero, y muchas gracias por la invitación a acompañarlo en este programa de educación en alergia que tanto interés ha generado en nuestros colegas y en nosotros mismos, porque es un tema cada vez más relevante en el que vienen además muchas innovaciones. Y tenemos el gusto en este programa de tener una doble certificación con Compedia, y quiero para eso invitar al doctor Benjamín Cepeda, alergólogo e inmunólogo pediatra, presidente de Compedia, que nos acompaña esta noche.
Hola, ¿cómo están? Es un placer para mí estar con ustedes, el haber contribuido en este gran esfuerzo a nivel de toda Latinoamérica en este RASH, Real Allergy Study Hall, y poder compartir con ustedes grandes ponencias. Es un programa de alto nivel internacional. Gracias, Oscar, gracias, Claudia, por estar aquí, por esta oportunidad. Y efectivamente tendremos certificación por parte de Cónica 9 puntos y por parte del Consejo Mexicano de Certificación en Pediatría 6 puntos. Así que disfruten mucho este evento. Estos próximos 4 martes estaremos aquí en este gran evento. Muchas gracias. Gracias por estar aquí.
Muchísimas gracias, doctor Benjamín.
Gracias, Benjamín. Por favor, todas las preguntas que tengan durante la sesión, los invitamos a que las compartan con nosotros en el chat.
Muy bien, y sin más preámbulos, entonces vamos a empezar. La sesión del día de hoy está enfocada principalmente en que hagamos un análisis sobre el diagnóstico de la alergia a las proteínas de la leche de vaca. Y para eso tenemos una invitada espectacular, es la doctora Karina Venter. Ella está con nosotros, se va a presentar y va a hablar con nosotros en los siguientes minutos sobre ese diagnóstico. Posteriormente vamos a volver a conectarnos para presentarles otra invitada que tenemos muy especial para conversar en esta sesión hoy y recibir todas sus preguntas y sus inquietudes sobre este tema tan importante. Nuevamente, gracias por estar con nosotros. Bienvenidos. Adelante, doctora Karina.
My name is Karina Venter. I'm an allergy specialist dietitian by background, and I'm currently based in Colorado, where I also have a position as Associate Professor of Pediatric Allergy and Immunology at Children's Hospital Colorado and the University of Colorado. Today we will be discussing a topic which is really close to my heart, cow's milk protein update, and give an update on the diagnosis and the management of cow's milk allergy with real focus on the diagnosis. I just want you to be aware of my disclosures, but none of these are relevant to my presentation today. This slide nicely summarizes the objectives for today. But what I really want to focus on in this next slide is the roadmap of the presentation. We will highlight each of these 10 points throughout the presentation. Cow's milk allergy is the most complex presentation of food allergy. It is also the most common presentation of food allergy, particularly in childhood. To make a diagnosis, history is key. It's important to always test when we can put context of the testing with the clinical context and symptoms, but just really blanket approach of testing is not advisable for any food allergy, particularly cow's milk allergy. We will talk about food challenges and how to use these to diagnose cow's milk allergy. We will talk about the two questions I most often get from patients. Can we predict the severity of their reactions? And can we predict when they will become tolerant to food? Talk about briefly avoidance and reintroduction using particularly the lather approach. And then finally, we will talk about how the milk lathers are used worldwide for the diagnosis and management of cow's milk allergy. So first of all, the different presentations of cow's milk allergy. Cow's milk allergy can be divided into IgE-mediated cow's milk allergy, as you can see here on the left side of the slide. This is basically where the child consumes cow's milk or yogurt for the first time, develop hives, swelling of the face. We do a test which support the symptoms, and we have a diagnosis of IgE-mediated cow's milk allergy. And most often these symptoms appear within 2 hours of cow's milk consumption. Then we have the much bigger umbrella of the non-IgE-mediated cow's milk allergy, as you can see here on the right side of the slide. Non-IgE cow's milk allergy includes food protein-induced enterocolitis, other forms of non-IgE-mediated cow's milk allergy, such as enteropathies, most often seen in gastroenterology clinics opposed to food allergy clinics, eosinophilic esophagitis, which is one of my areas of particular interest as well, and then mild to moderate non-IgE-mediated cow's milk allergy, which we will discuss a little bit in more detail today. But really, in order to make the different diagnosis of the non-IgE-mediated forms of cow's milk allergy, I would say that my main precision medicine tip today, and I will highlight that again later on, is the more symptoms a child has, the more likely they are to have a diagnosis of cow's milk allergy. So if we then go to the next slide, but I just want to highlight also first that really cow's milk allergy is the most complex presentation of food allergy in early childhood. So if you have read some of my papers, you'll know that I've spent about 10 years of my time on the Isle of Wight studying the prevalence of food allergies, once again with a focus on cow's milk allergy. And here on this slide, we have highlighted for you the percentage of the prevalence of food allergies. And as you can see, it varies widely, starting at about 1.1% in Thailand, and it works up to about 10.4% in Australia. Within most of these prevalence percentages we're showing you of food allergy, there's a large percentage coming from cow's milk allergy. The Isle of Wight data, for example, at 1 year of age, about 80% of the food allergies that we diagnosed were driven by cow's milk allergy, and very similar data we have from the South African data. So really, if you want to understand more about food allergies in your particular country and what percentage of overall food allergy is made up by cow's milk allergy, it's definitely worth investing in reading the papers to get more detailed information, because it's not really a matter of one size fits all for all countries. So to summarize this slide, cow's milk allergy is one of the most common presentations of food allergy, particularly in early childhood. Moving then to the next slide, it's important to understand that cow's milk allergy is not really caused by one single protein. There's a number of proteins involved in triggering symptoms relating to cow's milk allergy. The casein proteins, which are the linear proteins, and I'll explain that further on the next slide, are very stable to heat treatment and makes up about 80% of the protein in cow's milk. And the whey proteins, which make up about 20% of the protein in cow's milk, are thermolabile, which means that if we bake, boil, or cook it, some of the proteins will be destroyed. And so if you can see here on the slide, first looking at the left-hand side of the slide, here you've got a nice milk protein. On the complete left-hand side of the slide, you can see the word milk. That is a linear epitope. So we can actually bake, boil, cook, or steam this aspect of the cow's milk protein, but we won't really be able to destroy the whole of this linear epitope. And so children that's allergic to the linear epitopes or the casein proteins tend not to be able to tolerate baked products until they outgrow their cow's milk allergy completely. If we look on this linear, on the slide again on the left-hand side, but we now look at the conformational epitope, which is just spelled MIL. And we then move on to the right-hand side of the slide where we've now cooked, boiled, steamed, or heated in general, the conformational epitope. You can see that it basically unravels. And now we have a situation where we can see the MI on the one side, and we can say the LK right next to it. So the immune system is not able to recognize this word spelled MILK as milk because the conformational epitope have now been denatured. And so the children that tend to be allergic to the conformational epitopes normally develop tolerance to baked products before they develop tolerance to unheated cow's milk. And this is really the basis of the milk ladders and baked milk challenges, which we will discuss further throughout the presentation. So I just wanted to give you a nice visual demonstration of the linear epitopes that you can cook, boil, or heat. Structure won't change, so the child allergic to the linear epitope will react to all forms of milk, but the children sensitized and allergic to the conformational epitope will become tolerant to baked or heated forms of milk. Good. If we now focus on cow's milk allergy, know that we've got a little bit of the technical aspects out of the way, and we will talk about history, testing if applicable, food elimination, and then the food reintroduction or the challenge. So history is key in the diagnosis of cow's milk allergy. It's important to think about the questions to ask, which we will get to on the next slide. Perhaps mom said the first time I gave him an infant formula, or the first time I fed the child a little bit of yogurt, he had a reaction. It's then important to ask what the symptoms are. If they are clearly reporting wheezing of the chest, angioedema, or swelling of the lips and face, and hives or urticaria, as it's referred to more in the medical world, it really sounds like we're dealing with a cow's milk allergy. And then you may want to ask, how soon did it develop? If it's within 2 hours, we think it sounds like perhaps if we interpret the history like an IgE-mediated cow's milk allergy, then you may want to confirm this by doing some testing, skin prick test or specific IgE test. And then if it's positive, think about onward referral. In terms of questioning, we may also find that mom says, I gave him milk for the first time. He had repetitive vomiting about 6-7 hours later. He was clearly distressed with a lot of crying. No, there was no rashes. There was no hives. There was no swelling of the lips. And then when we interpret the history, we may think it sounds more like a non-IgE or a delayed type cow's milk allergy, where we may or may not do testing. We will get to that later on. And then think about onwards referral. So really this history taking is key to tell you which food are we talking about, which symptoms did the child experience, how soon did it develop, so that you can then decide which mechanism you think is underlying the cow's milk allergy, will you test, and how will you interpret the test. So history is really key. The important questions to ask, we have discussed this in the paper referenced at the bottom of the slide. It is really ask about if there's a family history of atopic disease. It can be any atopic disease such as asthma, eczema, or allergic rhinitis, or seasonal allergies as it's often referred to here in the United States. You want to ask about the sources of milk that currently is consuming and whether he tolerates or she tolerates it safely or not safely. So an infant that's been on mixed formula for a long time is unlikely to be reacting to cow's milk all of a sudden. But if you've had a child that was fed exclusively with breast milk who now reacts to first introduction of yogurt or first introduction of infant formula containing cow's milk, makes the diagnosis much more likely. We ask about the symptoms. It's important to ask about poor growth. As you've heard during the introductions, Dr. Roseanne Meyer is really an international expert on the issue of growth, particularly relating to cow's milk allergy. And then we also want to ask about other management and medication, because if you're dealing with a child that's already wheezing all the time, has had treatment for eczema, and now seem to have a reaction to cow's milk, make the diagnosis of cow's milk allergy much more likely than a happy, healthy baby that's never had any other allergy-related medical issues, although that can, of course, occur. So there are some cow's milk allergy scores, and I think, this is probably one of the most debated topics in the field of food allergy and also in the field of cow's milk allergy. And this is really where the history and the clinical skills of the pediatrician, gastroenterologist, allergist, or other healthcare professional taking the history comes in so very important, because just a crying baby doesn't necessarily have a cow's milk allergy. A baby that spits up every now and then, once or twice a month, doesn't necessarily have a cow's milk allergy. A baby that's almost never constipated and then have 2 days of constipation, or really has got no problems with diarrhea, but now all of a sudden develop a bit of diarrhea, doesn't necessarily have a cow's milk allergy. And so we can go through the list of symptoms shown here in the middle of the slide on the coma stool, as well as the symptoms shown on the left-hand side of the slide. So it's, again, like I said, it's the whole picture, the whole history. We want to ask about symptoms, how often, how severe, how many different symptoms. And then as the picture is building and we are finding more and more symptoms with increasing severity, so does the possible diagnosis of cow's milk allergy become much more possible than a child with just 1 or 2 single episodes of diarrhea, for example. But I did wanted to highlight these scores just for your information. So then, now we've talked about the history, which really applies to both non-IgE and IgE-mediated cow's milk allergy. And so just focusing on the next few slides on the diagnosis of just IgE-mediated cow's milk allergy. So first, I would like to ask you a question. Should we perform testing to make or to help make a diagnosis of IgE-mediated cow's milk allergy? The testing could be A, skin prick test, B, specific IgE test, C, component result diagnostic test, which I'll explain on the next few slides, but it's basically a test that helps us to test for caseins separately from testing for whey sensitization, any of the above, or no need to test. Specific IgE test and component resolved diagnostic test requires to do a blood draw, and then the tests are being analyzed in the immunology lab. We may want to do initial food avoidance, particularly if we're not clear which allergen are involved and if it really is milk. And then we really want to make sure we completely take the allergen out of the child's diet before we then do a food challenge to confirm. I want to just talk about this for a little bit. If it's a clear history, like I said, the child had milk or yogurt for the first time, within 2 hours, very clear symptoms of IgE-mediated food allergy, we do test and they react. Then in many cases in clinical practice, we won't do an initial food avoidance followed by a food challenge. We will just ask the family to avoid the food because we have made a clear diagnosis based on the history and the testing until we decide that we will do a follow-up challenge to see if the child developed tolerance to the food. So testing should really always be done in the context of a clinical history and symptoms, and I'll highlight that again for you on the next slide. So this is a beautiful algorithm published by the British Society of Allergy and Clinical Immunology. And if we can first start on the left-hand side of the slide. So here we have a child with a history. That is key. We have a history of symptoms. Now we can do skin prick test. We can look at the size of the skin prick test. If it's below 3 millimeter, we could still make a diagnosis, but in many cases, we may want to consider doing blood tests to try and support the finding we got from the skin prick test, and we may even consider doing an oral food challenge. Based on the guidelines from the British Society of Allergy, if we have a history, we have a skin prick test and it's above 3, we're likely to make a diagnosis of cow's milk allergy, In some individual cases, we may still go ahead and do a food challenge, but I would say in the majority of cases, you have a history, skin prick test equal or above 3, you know that you're dealing here with a child with cow's milk allergy. On the right-hand side of the slide, it's important now to remember, here we have no history of cow's milk allergy. First of all, we shouldn't be testing this child, but let's pretend we have a kid here and brother or sister have a very severe allergy to cow's milk or even perhaps peanut. Parents are very anxious to introduce cow's milk into this child's diet, and they ask if you could please do a skin prick test or specific IgE test, but we have no history of this index child ever reacting to cow's milk. So now we perform a skin prick test based on the family's preferences. We get the result 0 to 1 millimeter. I think it would be safe to say that this child does not have a cow's milk allergy, and the parents can go ahead and safely introduce cow's milk into the child's diet. We may still have some families where they will ask you to please bring the child in for an oral food challenge to milk, which we will do based on family preference, but that wouldn't necessarily be a clinical decision. So 0 to 1, we can say no cow's milk allergy. If we have a skin prick test of 2 to 4 millimeter, now we don't really know whether we're dealing with a cow's milk allergy. In that case, we would say, come into hospital. We're not telling you your child's allergic. There's some sensitization going on, but we want to do an oral challenge to see if they can perhaps tolerate cow's milk. If in this child with no history, we have a skin prick test or above 5 or equal to 5, in some cases, you're probably okay to make a diagnosis of cow's milk allergy. If you have a center where the child could probably have a challenge to milk the next day, like in the center where I'm currently working, we would even bring this child in for a cow's milk challenge. But in situations where there is not the clinical access to oral food challenge rooms or, within the next month or so, we could make a diagnosis of cow's milk allergy based on the skin prick test cutoff point. But I cannot emphasize enough, these cutoff points are helpful to make a clinical decision. It's not 100% indicative of allergy or no allergy. So we always have to take the clinical picture and the whole family situation into account before we make a diagnosis. Other than the British Society guidelines, there's also been other cutoffs published. These are mainly data from Spain and the United Kingdom. And so here we can say if we have a specific IgE to cow's milk in children 2 years or below of above 5, we're likely to say the child have a milk allergy. You can still challenge if you want, and that's your clinical decision. And in children above 2 years of age, you can see the cutoff goes up to above 15. Again, in rare circumstances, we may challenge with this specific IgE above 15, but 15 or above in the majority of cases indicate cow's milk allergy. And then if we look at skin prick test, again, we've got 95% predictor values. Like I've already said, it's not 100%. So here on the right-hand side, if you have a child 2 years or below with a skin prick test of 6 millimeter or above, likely to have cow's milk allergy, and in older children above 2 years of age, if the skin prick test is 8 millimeter or above, once again, highly likely to be milk allergic. So I do think that if we look at the British guidelines on the previous slide and the cutoffs I'm showing you here on this slide, it is very helpful if you're working in a situation where you can just not perform food challenges in every child. So then, looking again at the major allergenic proteins, I just wanted to highlight once again that we have the casein allergens, which are linear and unlikely to be destroyed by heating or cooking, although there's some level of reduction of allergenicity, but not a lot. And then we have the whey proteins, which are conformational and is mainly destroyed, or the allergenicity is mainly destroyed when we expose it to heating. So moving on then to milk oral food challenges, we've got 2 reports or 2 papers published on how to perform oral food challenges. The one on the left-hand side of the table is the oral food challenge report from the American Academy of Allergy, Asthma and Immunology by Anya Novak. And these challenges are performed by using cow's milk powder, which you can then divide into about 8 or 10 dosages and feed to a child. often used in clinical practice. If we look at the right-hand side of the table, which is the practical guidelines for performing oral food challenges, we mainly use these oral food challenges for research purposes, and it's because we start with very small dosages that are very hard to measure out. As I've done many of these in my life, I know they are extremely time-consuming, and so the practical guidance I do want you to be aware of, but it's not normally used in clinical practice. But then following on from the guidelines published by Dr. Anya Novak, which I've shown on the slide as the milk powder divided into 8 or 10 dosages, we now have the follow-up guidance from the American Academy of Allergy, Asthma and Immunology. It's a paper published by Dr. Drew Bird. As you can see on the slide, it beautifully shows us how to take normal portions of cow's milk. So I definitely like the practical aspect of these guidelines. Normal portion of cow's milk, cottage cheese, hard cheese, and yogurt for children of different age groups. And when you take this normal portion, you just divide it in either 4 dosages or 6 dosages. The practical guidance or tip I can give you about this is if we are dealing with a young child, which we think may not react, but we just really want to get the full dose in the child, we normally would use a 4-dose protocol. We tend to use the 6-dose protocol, particularly if we are concerned that the child may have a reaction. And then clearly the first dose of a 6-dose protocol is much lower than the first dose in a 4-dose protocol. But if you are a clinician and you're perhaps based in primary care and you may not have access to a hospital setting to do these challenges, but you have got all the other safety measures in place like anaphylaxis kit, etc., then this is a very pragmatic approach to performing oral food challenges. And I really want to make the point that if there's any doubt whether a child is truly allergic to milk, it's worth bringing them in for an oral food challenge, because we do not want children to be avoiding foods indefinitely that they haven't got a clear diagnosis to. So the oral food challenge report from 2019 has now been replaced by the latest work group report from the Quad AI, and I've already referred to Dr. Bird, but you can see the reference there at the bottom of the slide. So the 2 questions I get from families is, how bad are the reactions going to be? And do you know when my child's going to outgrow the cow's milk allergy? So focusing on the first question, can we predict severity of reactions? There's some evidence to show that STAT6 gene variants are associated with more severe allergic reactions, but clearly we don't do genetic tests to our patients in clinical practice. This is very much research data at this point. And then we've also seen a significant association between anaphylaxis when we do an oral food challenge and specific IgE levels to casein. So this is once again where the component resolved diagnostics come in. It's one thing to know that the child has got a specific IgE level above 15 for milk, or that the child may have a specific IgE level of 5 to milk and a skin prick test of 6 millimeter. But if we do component testing, we may get a better indication of whether they will tolerate baked milk or not, and also how bad their reactions may be during an oral food challenge. But at this point in time, there's no reliable test to predict how severe reactions will be on consumption of cow's milk. So we're not able to predict severity, and one of the reasons is many cofactors may be involved. In adults, we know that when they drink alcohol or if they are sleep deprived, they may be more prone to having severe reactions. In children, if they have any intercurrent illness, such as a cold or a flu, their tolerance level may drop and they may tend to react to smaller amounts, and the reaction severity may increase as well. So then getting to baked milk proteomics and the question of, is my child going to outgrow their cow's milk allergy quicker, and will they be able to tolerate baked forms of milk? Mothers tend to go on social media a lot nowadays, and so they have all these questions. So the good news is the majority of cow's milk allergic children can tolerate heated milk. Once again, if you have your component resolved testing done, they have very low levels to casein, but higher levels to whey, then perhaps they're more likely to tolerate heated milk, because it's the whey that's triggering their symptoms, and we can destroy the whey in food when we bake. cook or heat it. Analysis of the protein profile using proteomics shows that immunoreactivity of baked foods with the wheat matrix is much affected. I would like to say I think we need more data. So basically what we're saying practically is if you feed a child a muffin with wheat and milk in, we can further reduce the allergenicity of the milk because there's a wheat component in it. I think all grains matter, whether it's quinoa flour or a rice flour, I think they all seem to have that inhibition of allergenicity. And so we safely conduct baked milk challenges with a combination of rice and tapioca flour, which also accommodates the children with wheat allergy. And the only residual immunoreactivity of baked products was because of the casein epitope. So once again, like I said, we can get rid of some allergenicity of the casein, but most definitely not more than 80–90% at best. So baked milk tolerant individuals, they have lower specific IgE to casein, and they have lower basal activation tests to casein as well, which again is still very much in the experimental phase. So we're not able to predict tolerance yet either, but we can probably predict tolerance to baked forms of milk, even though we still bring them in for a challenge. So that sort of like summarizes the IgE-mediated aspect of the talk. I think I've nicely highlighted, or I hope I've clearly highlighted. We ask about the history, we decide about testing, and then we may initially avoid the food followed by a food challenge, or if we're very clear about the diagnosis based on our history and testing, we may advise long-term avoidance of the food until we do a food challenge to see if the child developed tolerance to either baked forms of the food or perhaps to unbaked forms of cow's milk. So on the next slide, we're now going to go to the diagnosis of non-IgE mediated cow's milk allergy. I have another question for you. Should we perform testing to make a diagnosis of non-IgE mediated cow's milk allergy? So if you think that the child definitely haven't got IgE food allergies or cow's milk allergy, there may be some delayed vomiting, reflux, diarrhea, and constipation, would you consider a test? Skin prick test, specific IgE test, patch testing, any combination of the above, or there's no need to test? No real reason to test for the involvement of IgE. And so the correct answer, like I've said, is no need to test. It is very difficult to diagnose these children with the mild to moderate non-IgE mediated cow's milk allergy. And so we therefore published the MAP guidelines. We realized that the MAP guidelines was used all over the world. And we then developed and published the international MAP guidelines, which are referred to as the IMAP guidelines. Before I go further to talk about the mild to moderate non-IgE mediated cow's milk allergy, I want to make it very clear that this presentation does not cover food protein-induced enterocolitis syndrome. It also doesn't cover eosinophilic esophagitis. Both presentations of non-IgE mediated cow's milk allergy, but not for the purpose of this talk today. So what is mild to moderate non-IgE mediated cow's milk allergy? These children, they usually present with atopic dermatitis or reflux, but they are resistant to treatment. Just seeing a child with some eczema or some dry skin doesn't mean they've got cow's milk allergy. If you have, however, treated them optimally for at least 4 to 6 weeks and there's no improvement in their skin symptoms, you may want to consider a milk-free diet. Reflux, of course, is the opposite to eczema because the NASPGHAN and international guidelines now recommend that cow's milk avoidance or use of a hypoallergenic formula is the first line of treatment of troublesome reflux. So you have a child with troublesome reflux, and I must say when you read the guidelines, it's always not that clear what exactly troublesome reflux means. But when you have the family in front of you, you will know that you are dealing with troublesome reflux because everybody's exhausted, mom is tearful, nobody has slept, and their washing machine is running nonstop. So in terms of troublesome reflux, even before you try any drug therapy, you may want to consider removing cow's milk from the child's diet. And like I said, treatment resistance, particularly in terms of atopic dermatitis, normally indicates that they may have a cow's milk allergy. They may have gastrointestinal symptoms such as diarrhea, constipation, just the constant screaming because of tummy ache, which we could refer to as colic or not colic, but they have clear gastrointestinal distress. And then we also talked about the skin symptoms. So, like I said, we did publish an update on the milk allergy guidelines, and the second update, which was published in 2019 with Dr. Adam Fox as first author, was really to highlight the importance of continued breastfeeding and helping the mom to exclude milk from her diet if she's breastfeeding, because we really always want to support breastfeeding as much as we can. And just having mild to moderate non-IgE mediated cow's milk allergy is not a reason to stop breastfeeding, particularly if mom is happy to take milk out of her diet for a trial period of 2 to 4 weeks. So I've got another question for you. So if we have a mother who is breastfeeding but using a supplement formula containing cow's milk, which is clearly adding to the child's distress and symptoms, or if we have a mother that is not breastfeeding at all and using a cow's milk formula and that's adding to the child's symptoms, which formula would you suggest for that initial 2 to 4 week period of avoiding cow's milk from the child's diet to make a diagnosis? Extensively hydrolyzed formulas or rice hydrolysates, amino acid-based formulas, plant-based milks like rice milk, oat milk, pea milk, soy-based formula, or any of the above formulas. I'm just going to let you think over it for a few seconds. Children with the mild to moderate non-IgE mediated cow's milk allergy. If we then go to the IMAP algorithm, it basically just highlights what I've already said. If mom is breastfeeding, we want to support her to take milk out of her diet, exclude milk for 2 to 4 weeks. If the child is getting better, then we must do a home introduction to confirm the cow's milk diagnosis. Many parents refuse at this point, but it is important to explain to them that we could make a misdiagnosis by just elimination and the baby getting better, because babies grow up, you know, and symptoms improve, perhaps irrespective of the milk avoidance diet. So important to reintroduce the milk to get that confirmation of diagnosis. And if the child is formula fed or on a mixed feeding, and we've changed the child's diet with an appropriate formula, once again, if the child gets better after 2 to 4 weeks, we reintroduce a cow's milk formula back in the child's diet to confirm the diagnosis. In both cases, if you remove milk, child's not getting better, you can just reintroduce it because it is clearly not milk causing the child's symptoms. There are many reasons why babies cry, have colic, have diarrhea, and have constipation, not relating to cow's milk allergy. But if you have then confirmed the diagnosis after 2 to 4 week avoidance, we normally say, we've now got a confirmation of diagnosis, we're going to avoid cow's milk from the child's diet for 9 to 12 months or at least 6 months. And then we can reintroduce it. In some cases, we may want to think about liaison with the local pediatric service. So how do we reintroduce milk into the child's diet after the 2 to 4 week of exclusion? First of all, in mom's diet, she can just really go back to normal consumption. It doesn't have to be graded. We don't have to say first some baked food and then trace amounts of milk and then bigger amounts of milk. We just ask mom to revert back to her normal diet as the amount of cow's milk protein when mom is consuming cow's milk is so small. So that's what we would do. And then if we want to change the child's formula back from the hyperallergenic formula to a cow's milk formula, we ounce by ounce from the first bottle of the day, we reduce the amount of hyperallergenic formula and we increase the amount of cow's milk formula until the child is back on a whole bottle, a 7-ounce bottle of cow's milk formula, in which case we can then change all the bottles back to a cow's milk formula. But if at any point during this reintroduction process, the child becomes symptomatic, then we've got a confirmation of cow's milk allergy and the child will be placed on a hyperallergenic formula alongside a milk-free diet in the weaning diet for about 9 to 12 months, but at least 6 months. I normally, again, my clinical experience is teaching me in this group of infants with the mild to moderate cow's milk allergy, symptoms will start to recur about day 3 and 4. It's normally not in the first 2 days, but it's possible as well. And then after the longer period of avoidance, we then start reintroducing milk back in the child's diet in a regulated process over a period of time. We've got here on the left-hand side of the slide the IMAP milk ladder, which has only got 6 steps. It's much more internationally suited. But we also have on the right-hand side of the slide the older milk ladder, which has got 12 steps. But as you can see, there are many UK foods such as shepherd's pie and Scotch pancakes. And we felt that we needed to condense the ladder into 6 steps and also make it more internationally applicable. And the other very positive point about the IMAP ladder is that we've removed all sugar from the cookies and biscuits. So the recipes all contain fruit for natural sweetness, opposed to sugar in some of the foods in the original milk ladder, but both can still be used safely. It's important that we should standardize ladders. You know, there's a reason behind this gradual approach of the ladder, going from a cookie and a biscuit to eventually ending up with an infant formula or pasteurized milk if the child is not using infant formula anymore. And so we've recently submitted a paper, which will hopefully be accepted soon. Dr. Meyer is one of the co-authors, where we suggested some standards for milk ladders. And we think that information on the dose of the allergenic food and the allergenic protein should be calculated, and protein content measures in a lab, if possible at all. The time and temperature of heating should be specified. Simplicity with one or a limited number of steps. So what we're trying to say here is it's nice to have a cookie in step 1 and a muffin step 2, opposed to 3 or 4 foods as step 1 and 3 or 4 foods as step 2, and all the way up the ladder, which can confuse families and make them very anxious because they don't always know which one to pick. We should look at the heat matrix. Is it really wheat or is it any grains? I've already touched on that. And testing the levels of allergenic protein, ideally both total proteins as well as the protein fraction. So we really need to know how much casein and how much whey is left after the cooking period. We also need to think about nutritional aspects, which I'm not going to go through in detail, but I touched on. We want to make sure the foods are healthy, there's not too much sugar and fat in, that taste and texture are acceptable, that they're appropriate for different cultures, and hence the IMAP ladder. I'm also just about to submit an Indian milk ladder as well as Mediterranean milk ladder. We want practical recipes and protein content I've talked about. And then there's also the medical aspects. When is it safe and where can we perform the ladders, and which patients are the best patients to undergo milk ladders opposed to patients that's better off to have a hospital home challenge. So interactive question number 4 is, which of the following is true? Using a milk ladder to diagnose tolerance development may. What's the good things about using a milk ladder? It may increase the variety of foods or biodiversity. Mom may spend less time reading food labels because the child will now be tolerant to, let's say, trace amount of milk, or we know that the majority of cookies or biscuits available in the store is safe for the child to eat. Cupcakes are safe to eat, so no need to check food labels. There's no concern, or less concern at least, about precautionary advisory labeling such as may contain. The child can go out to birthday parties now because they can have a slice of birthday cake, or all of the above. Many other positive aspects of using a ladder approach in the management and diagnosis of cow's milk allergy. So we did an international survey. I was really surprised when we got the data back. You will see that the milk ladder is used for IgE-mediated food food allergy as well. And when we initially published it, we made it very clear that it's really indicated for non-IgE food allergy, but it's used in hospital and home, and some places they use it in both settings. So the milk ladders are clearly used worldwide for the diagnosis of cow's milk allergy. And we also wanted to look at how the milk ladder is being used in non-IgE mediated food allergy. Again, very high uptake of the ladder approach. And not surprisingly, in this case, in the majority of cases, ladder approaches are used at home. Is the milk ladder safe? We just asked the doctors or the healthcare professionals who completed the survey, is it safe? The majority felt it was safe for non-IgE mediated food allergy. Not everybody thought it was safe for IgE mediated food allergy, but still about a third thought it was safe. And then we looked at whether it truly is safe, not just an opinion. And again, on this slide, you can see that it doesn't matter whether a child has IgE-mediated food allergy or non-IgE-mediated food allergy. Clearly, when we start working our way up the ladder, the children has some symptoms, not unexpectedly, because we are trying to push them up the ladder to try and find out where their tolerance level lie. But always important, if you look here at the middle of the slide, right next to anaphylaxis, there are still some children who develop anaphylaxis to both baked milk challenges and the milk ladder approach. So be careful if you think a child is at risk of anaphylaxis to use the milk ladder approach at home. That's perhaps not the best patient to choose. But when we look at the symptoms in the children with the non-IgE mediated cow's milk allergy, by definition, we wouldn't expect these children to have anaphylaxis because it's an IgE mediated triggered symptoms. But nice to see from this international survey that yes, they do have symptoms, but none of these symptoms tend to be severe and end up with hospitalization. So it's a really safe approach for the mild to moderate non-IgE mediated cow's milk allergy. And then I'm getting to the end of the talk now. COVID-19 has changed the world. We have to do food challenges via teleconferences. We have to introduce peanut at home at mass in babies where perhaps we would have brought them into hospital, skin prick tested them, and then performed an oral food challenge in hospital. The same is happening to the management of cow's milk allergy. We do not have the ability to bring all the children into hospital. Parents don't want to come into hospital. They don't want to risk being exposed to COVID-19, particularly if they have young children or perhaps a grandparent living in the house that's at high risk of having more severe reactions or becoming more affected by COVID. And so we have to think outside of the box. And I think using the milk ladder approach give us the ideal opportunity to think about the diagnosis and the management of cow's milk allergy safely at home, perhaps with some supervision from the physician via telemedicine. And I think papers like this one explaining about introducing peanut at home in young infants via telemedicine will be published much more often in future. And so really in summary, we've gone through the 10 points. Cow's milk allergy is complex, it's common, we have to take a history, we can test if we know how to interpret it in IgE-mediated cow's milk allergy. Food challenges, if you have any doubt, is still the best way to know whether you've got a child with cow's milk allergy. We can't predict severity, we can't predict tolerance, but baked milk is giving us some help with managing these children better. If for non-IgE-mediated cow's milk allergy, particularly mild to moderate, we want to avoid the food and then reintroduce it. After 2 to 4 weeks, please try and get the families on board. Then after prolonged avoidance, we can do the milk ladder at home. And clearly, milk ladders are here to stay. They're being used worldwide for the diagnosis of cow's milk allergy. And I'm hoping to publish my Indian and Mediterranean milk ladder with colleagues from Greece as well as India soon. Thank you very much.
Muchísimas gracias, doctora Karina, por tu presentación. En estos minutos nos has mostrado fundamentalmente la parte práctica de cómo hacer el diagnóstico. Siempre tenemos muchísimas preguntas que vienen de la información que estudiamos, que leemos, que compartimos, de las guías internacionales, de las últimas publicaciones, pero al final el gran reto es traducir toda esa información científica en actuaciones prácticas dentro de nuestro consultorio cuando estamos teniendo un paciente alérgico y necesitamos resolver específicamente su problema. Entonces, muchísimas gracias. Gracias a todos los colegas y amigos, más de 2.000 colegas y amigos alrededor de toda Latinoamérica que se han conectado a nuestra primera sesión de RASH, este programa de educación médica en conjunto de Compedia con Abbott, para los especialistas profesionales de la salud que desean aprender más sobre cómo apoyar a los niños con alergias alimentarias. Recuerden que el programa comprende 4 sesiones que se llevarán a cabo los próximos 4 martes en este mismo horario y que contamos con una doble certificación por parte de Compedia y por Abbott. Recuerden que es muy importante para alcanzar la certificación que asistan a por lo menos 3 de las 4 sesiones que tendremos y posterior a la última sesión tendremos una semana habilitada en la plataforma para que puedan presentar una prueba que deben pasar y una encuesta para que puedan descargar sus certificados. Recuerden que esta sesión, así como todas las 4 sesiones, esta en particular, en las siguientes 12 horas estará disponible para que si nos quieren ver de nuevo en esta grabación, nos pueden ver desde el principio hasta el final, tomar datos, tomar apuntes, tomar los datos que les parezcan más relevantes, más importantes y por supuesto seguir creciendo en el aprendizaje sobre la alergia a las proteínas de leche de vaca. Muchísimas gracias. Doctora Claudia, muchas gracias y tenemos una invitada muy especial para que podamos conversar al final de esta sesión de hoy.
Es muy interesante, doctor Tintero, porque esto que usted dice de traer este conocimiento a una práctica clínica es realmente el reto del día a día de la mayoría de los colegas que nos acompañan. Y para eso quiero invitar a una pediatra muy reconocida en Latinoamérica, la doctora Marcela Fama, expresidente de la Sociedad Colombiana de Pediatría y vicepresidenta de ALAPE, para que nos acompañe en esto de bajar la teoría a la práctica clínica.
Gracias, Claudia, y gracias, Oscar, por esta invitación, por estar aquí esta noche. Y bueno, la doctora Karina con su magnífica presentación y a todos gracias por acompañarnos esta noche. Y bueno, intentaremos, Claudia, ese reto de bajar esa información y esa evidencia que tenemos a la práctica diaria nuestra, pues como clínicos.
Y en eso, doctora Marcela Fama, usted como pediatra compartirá que probablemente la primera aproximación que tienen los padres a los profesionales de la salud cuando los niños tienen manifestaciones clínicas de alergia a la proteína de la leche de vaca es al pediatra. Es el personal de salud que está más cerca de los padres, más cerca de los niños y de la persona que tienen más cerca y que tienen en confianza. Cuéntenos usted un poco, ya la doctora nos dio como las estadísticas, pero ¿cómo se vive realmente? ¿Cuál es la consulta más frecuente que ustedes como pediatras tienen en relación a síntomas de los niños que tienen alergia a la proteína de la leche de vaca?
Bueno, muy interesante, Clau, porque definitivamente sí, somos el primer punto de contacto de esos padres que llegan de pronto desesperados con algunos síntomas inespecíficos, porque sabemos que la alergia a la proteína de la leche de vaca tiene un espectro de manifestación clínica muy amplio, así como la intensidad de las reacciones y de los síntomas que tienen los niños, pues varía mucho en su presentación. Pero de los síntomas más frecuentes que nosotros vemos en la consulta en el día a día, pues podemos tener niños que generalmente tienen cólico, pero interpretado un cólico patológico, el cólico que es el niño que llora intensamente de una manera excesiva y muy frecuente, niño que además puede presentar reflujo durante o después de la alimentación, niños que los papás consultan porque el niño se alimenta, presenta distensión abdominal, en algunos casos cambios en ese hábito intestinal, a veces constipación, a veces con diarrea, y algo muy importante que que vemos muy frecuentemente en la consulta, sobre todo en los niños muy pequeños, que son las deposiciones con sangrecita. Entonces, eso es un hallazgo muy frecuente por el cual los papás consultan, porque pues sigue siendo alarmante cuando ellos van a cambiar el pañal, un niño que está molesto, llorando, irritable y tiene pues la sangre también en la deposición. Entonces, todos esos son síntomas que pueden manifestarse, que pueden presentarse, por los cuales los consultan, pero que tenemos que evaluarlos en un contexto de una historia clínica donde tenemos unos síntomas que tenemos que analizar en este contexto. También podemos ver otro tipo de manifestaciones, no solo a nivel gastrointestinal, sino también esas manifestaciones que se pueden dar en piel, que son los niños que presentan rash o una dermatitis atópica, que pueden tener incluso con edemas, por ejemplo, edemas en la cara, en la lengua, y este tipo de manifestaciones que pues nos hacen pensar mucho más fácilmente ahí sí en un problema de tipo alérgico. Y menos frecuente, pero que también se puede presentar, pues los niños que presentan compromiso respiratorio como rinitis y sibilancias y eso también. Entonces mira que es un espectro muy grande de síntomas y de manifestaciones por los cuales los padres nos consultan y que nosotros tenemos que enfocarnos y pensar que ese niño puede estar cursando con una alergia a la proteína de la leche de vaca.
Hay varias preguntas en el chat, pero ya que lo tocaste, vamos a traer ahora las preguntas del chat, pero ya que tocaste estos síntomas, el llanto, el reflujo, estos son síntomas muy frecuentes en los niños, no necesariamente en niños con alergia a la proteína de la leche de vaca. Es difícil diferenciar en el consultorio para ustedes en ese primer, digamos, acercamiento, probablemente para los gastropediatras, como ya son niños que llegan con una consulta previa del pediatra, con consultas de pronto en los servicios de urgencias. Nosotros tenemos como un tiempo de evolución más largo en general de la sintomatología. Es como podemos ver la enfermedad en una evolución más larga. Cuando ustedes los ven por primera vez y consultan, es difícil hacer ese diagnóstico o cómo se orientan para, por ejemplo, pensar que es alergia a la proteína de la leche de vaca y no un síntoma del llanto o la regurgitación que tiene habitualmente el lactante.
Bueno, claro, inicialmente la clave de todo es una historia clínica adecuada. Eso es fundamental, saber en esa historia clínica la presentación de esos síntomas, cómo están asociados, en qué se manifiestan, saber obviamente qué alimentación está recibiendo nuestro paciente para nosotros poder pensar en este tipo de situaciones. Hay algunos scores en los cuales nosotros podríamos utilizar también, que son una herramienta, no son un método diagnóstico, pero son unas herramientas en las cuales uno vamos haciendo como un check y tratamos de objetivizar quizás un poco estos síntomas. Entonces, a veces es difícil saber en qué momento son solamente unos síntomas digestivos menores o cuando realmente tenemos que pensar que sea una alergia a la proteína de la leche de vaca. Lo importante es no irnos en el exceso ni en el defecto, sino poder enfocarnos, tener presentes que esas manifestaciones por las cuales los papás nos están consultando, nosotros podríamos pensar que sea una alergia a la proteína. Y lo otro es que dependiendo de esto, pues tomar decisiones sobre si vamos a retirar el consumo de la leche de vaca, que de pronto lo podemos hablar más adelante, cómo es si el niño está con lactancia exclusiva o no, y poder mirar estas pruebas de reto y todo, que de pronto sería el paso a seguir que me gustaría que conversáramos y de pronto ahí sí te la devuelvo un poquito. O sea, entonces, en estos niños que nosotros por la clínica, por la historia, el contexto en el que tenemos, podemos sospechar que el niño sí pueda tener una alergia a la proteína de la leche de vaca, entonces, bueno, ¿cómo empezamos a hacer todo este proceso y definir en qué momento hacemos pruebas de alergia? Porque bueno, cuando tenemos los mediados por IgE, pues realmente es mucho más fácil tomar decisiones, ¿cierto? Pero cuando son ese otro espectro grande, entonces sí me gustaría como el concepto tuyo y de pronto por ahí está Osquiter también, a ver ese concepto que tiene, en qué momento decidimos hacer esas pruebas.
Sí, pues muy interesante lo que dices, Marce, sobre todo, por ejemplo, estos scores como el COMIS, son cosas que se pueden hacer al lado del niño, no necesitamos cosas especiales, en la manifestación en piel, en las características de la deposición, incluso la ubicación de las manifestaciones en piel, el llanto, los síntomas respiratorios. dan como más herramientas para pensar en la alergia, en esto que hablamos a veces puede haber un sobrediagnóstico en que se cruzan los síntomas con trastornos gastrointestinales funcionales, incluso con el comportamiento habitual que puede tener un lactante. Y ya nos decía, pues, y esto trayendo algunas de las preguntas que hay en el chat, las cuales agradecemos muchísimo que estén haciendo y que tengan su participación, porque nos han preguntado, por ejemplo, algo muy parecido a lo tuyo, ¿no? Que biomarcadores serológicos se hacen, desde cuándo se puede hacer, desde qué edad se puede realizar un prick test, cuándo se debe realizar. Y fíjate que ya en la conferencia nos decía la profesora, no hay en las alergias que no son mediadas por IgE, realmente el diagnóstico sigue siendo la prueba de reto. Y esto es muy importante porque también es otra de las preguntas, ¿están de acuerdo con retar? Pues finalmente es lo que nos puede completar el diagnóstico y aunque angustia un poco, por ejemplo, la deposición con sangre a la mamá o que vuelva a tener diarrea, el compromiso que ha tenido en peso, es la forma en la que podemos, en las que no son mediadas por IgE, pues garantizar el diagnóstico porque sí es un reto no solamente pensar en la exclusión, sino, por ejemplo, en una mamá que tiene lactancia materna y que se ha comprobado que la alergia es a través de la leche humana, pues hacer una dieta de exclusión por 6 meses y el tiempo completo de tratamiento. Entonces, el reto no solamente es el diagnóstico y por eso vale la pena pensar y motivar a los colegas a que completen el diagnóstico porque el completarlo significa y favorece que tengamos el tratamiento para los niños que lo merecen y el tiempo pues que lo requieren. Entonces esto ayuda también a las familias. Las pruebas de prick test y de IgE pues se pueden hacer desde recién nacidos, ya lo hablábamos por ejemplo en alguna ocasión con el doctor Benjamín, pero la mayoría de alergias pues no son mediadas por IgE. Entonces es importante saber que no son estas pruebas, y también lo veíamos en la charla, las que nos pueden hablar de alergia y que los síntomas que tiene el niño son por alergia, porque las pruebas al final de anticuerpos IgE son pruebas de sensibilización, no necesariamente de manifestación de alergia. Entonces es muy importante dejarlas para aquellos que tienen síntomas mediados por IgE o aquellos que tienen una evolución compleja y decíamos, la doctora decía, bueno, esto no es la enteropatía asociada a la ingesta de proteínas, ¿cierto? La enterocolitis, que es como una manifestación diferente. Y bueno, hay muchas preguntas también en el chat, las cuales agradecemos sobre el tiempo de tratamiento, cuáles son las mejores, cuál es la elección en el tratamiento, y en eso pues queremos invitarlos a que vamos a tener unas sesiones más adelante específicamente para hablar del manejo con casos clínicos, los cuales también van a estar muy, muy interesantes.
Oye, y hay muchas preguntas que tienen que ver, discúlpame, Marce, que tienen que ver
Sí.
específicamente con esta aproximación de diagnóstico. Y fíjense que la doctora Karina en su presentación nos ha llevado un poco a ese aspecto más práctico. Nos ha mostrado las guías y nos ha mostrado cómo podemos aplicarlas en el día a día. Y creo que un punto que nos permite avanzar de forma general en la práctica es, con una muy buena historia clínica, como tú dices, Marcela, es tener ese punto de partida y sobre todo distinguir los pacientes que tienen una alergia mediada por IgE versus no mediada por IgE. Creo que eso es lo que hace el primer gran paso, porque en la práctica general puede ser que estemos pensando en pruebas específicas, en pruebas dermatológicas, en pruebas de sangre, pero además hay muchas otras pruebas que los pacientes tienen acceso o que podemos haber hecho previamente, exámenes generales de sangre, exámenes de la materia fecal, y muchas veces las preguntas es si yo tengo específicamente hallazgos en materia fecal o en una biometría hemática, en un cuadro hemático, ¿puedo hacer un diagnóstico específico de alergia? Y la respuesta claramente es que seguimos basándonos en lo que es la clínica específicamente y por supuesto en las pruebas de reto, el reto que es lo que nos da la manera de poder seguir más adelante. Y hay algunas preguntas que tienen que ver, Claudia, fíjate, con la seguridad de hacer ese reto, ¿no? Siempre es una preocupación y en la clínica lo es, porque exceptuando, claro, la anafilaxia, que por supuesto no consideramos hacer un reto en condiciones no controladas, pues a veces en la práctica como que después de que tenemos la sospecha y queremos hacer una prueba de reto, probablemente los padres no van a querer hacer un reto y volver a tener sangre en las evacuaciones o cualquier otro problema. Entonces, es la gran dificultad de llevar las guías a la práctica en general. Entonces, no sé qué opinas, doctora Marcela, doctora Claudia, sobre esa forma de cómo podemos llevar un poco mejor solamente la clínica y cuándo dar ese paso a todos los otros exámenes como nos están pidiendo aquí. Y hago énfasis en el punto que tú dices, doctora Claudia. Hay muchas preguntas sobre el tratamiento en particular, el tiempo de restricción de la proteína y lo demás, y por supuesto vamos a tener una sesión específica para el tratamiento. ¿Qué opinan ustedes, doctora Claudia, doctora Marcela?
Gracias, Víctor. Bueno, como nos llega primero el paciente al consultorio o al hospital, dependiendo, entonces tenemos primero unos síntomas que tenemos que definir con una historia clínica en el contexto de nuestro paciente, porque igual para empezar siempre tenemos que tener esa aproximación diagnóstica inicial con la historia clínica. Ya lo mencionaste, lo mencionamos en la charla, toda la parte de anafilaxia, pues no tenemos discusión, no vamos a someter al paciente pues a un reto sabiendo que tiene un antecedente de esto. Pero como el gran paraguas grande abarca todas las no mediadas por IgE, que son todos estos síntomas molestos, cuando realmente sospechamos que si es una alergia a la proteína, podemos hacer con una buena comunicación con los papás, que eso es fundamental, poder uno tener ese grado de comunicación y de confianza con los papás, que estamos ahí acompañándolos y vamos a hacer el seguimiento de los algoritmos, ¿cierto? Entonces, se puede hacer en la práctica, da tranquilidad porque tú lo puedes hacer en la casa, con una comunicación constante con los pacientes y entonces hacer la eliminación por ahí hay una preguntita que estaban haciendo sobre cuando el niño está con lactancia materna exclusiva. Entonces, bueno, lactancia materna exclusiva, hacemos dieta de eliminación de lácteos a la madre, 2 a 4 semanas, miramos si desaparecen los síntomas y ahí empezamos nuevamente con el derrotero de reintroducir y mirar basados en una relación de comunicación y de seguimiento de nuestro paciente. Entonces yo creo que sí lo hacemos y sí lo hacemos en nuestra práctica diaria y es como generar esa confianza para poderlo hacer. Porque si no lo hacemos y nos vamos por ahí, pues ya nos tenemos que quedar mínimo 6 meses en este proceso, mínimo, recordemos que más o menos de 9 a 12, entonces yo creo que sí es importante hacer un diagnóstico mucho más asertivo y esa es la manera que tenemos de hacer.
No, de acuerdo, Marce, y creo que pues, lo que decía el doctor Oscar Quintero y es cómo cuando son reacciones severas y hay anafilaxia, pues claro, ese es el momento y creo que era un poco lo que nos llamaban la atención en el chat, la necesidad de en ese contexto de niños con alergia mediada a IgE, donde la manifestación en una segunda exposición incluso puede ser más severa que la primera, pues se haga dentro de un contexto hospitalario con todos los cuidados, con esa dosis ascendente, por ejemplo, que implica el reto. Y en general, solo si las IgE han dado negativas, porque si la manifestación fue muy severa y la IgE es positiva, pues evitaríamos el reto pues, por el alto riesgo que tiene el niño, ¿no?
Sí, de acuerdo.
Y déjenme hacer un comentario respecto a lo que tú decías, doctora Marcela, por ejemplo, los lactantes que están siendo exclusivamente alimentados con leche materna y este tema de la dieta de exclusión a las mamás y cómo tenemos en los últimos meses publicaciones que han empezado a tratar de darnos otro camino y a sembrar una duda respecto a cómo se debe hacer esa restricción y cuál es el impacto verdadero dentro de la evolución de la historia natural de lo que es la presentación de la alergia en estos bebés pequeños. Así que ese y otros temas los tendremos en la sesión de tratamiento, que son las cosas que vienen actuales y que probablemente necesitemos ir adaptándonos un poco a la forma como va variando el conocimiento en particular. Tenemos más preguntas acá. No sé si tienes alguna en particular, doctora Claudia, que quieras comentar.
No, creo que tienes toda la razón, por ejemplo, en relación a la lactancia materna, creo que los niños se puede presentar la alergia a través de la leche humana, pero ya las guías vienen con una indicación diferente en cuanto a si el niño ha presentado síntomas solo con la fórmula, no deberíamos hacer exclusión, por ejemplo, a la mamá, pero lo vamos a ver como pues, más adelante en una forma más amplia. Nos preguntan, por ejemplo, por el eritema perianal, puede ser una cosa en la que pensemos, los cólicos, y creo que todo esto lo hemos explicado ya juntando los síntomas, por ejemplo, el cómic, y cómo tratando de estratificarlos, uno tiene suficiente, se llena de más razones para empezar una dieta de exclusión y no hacerlo ante, como lo decía la doctora Karina, el primer vómito o el primer episodio de estreñimiento, de disquesia, ¿no?
Sí, es que son síntomas que pueden presentar un niño sin tener alergia a la proteína, pero cuando estamos hablando de alergia son síntomas recurrentes en un niño que en un contexto de un paciente que tiene una presentación o una historia clínica ya con estos síntomas recurrentes. Entonces yo creo que sí es importante los score o el COMIS nos ayuda a objetivizar quizás un poquito más ese contexto sin que aclarando que no es una prueba diagnóstica.
De acuerdo.
Muy bien, fantástico. Muchísimas gracias, doctora Claudia, doctora Marcela, por participar de esta conversación. Ha estado también tras bambalinas el doctor Benjamín con nosotros, acompañándonos, luego de ver esta presentación fantástica de la doctora Karina Venter, en que en esta primera de nuestras sesiones del programa hemos hecho una aproximación hacia el diagnóstico. Recuerden ustedes que este es un programa que estaremos 4 semanas, los próximos 4 martes a esta misma hora. Esta sesión quedará grabada para que en las siguientes 12 horas puedan conectarse y verla si quieren de
Una
vez.
semana, doctor Quintero, nos han ampliado hasta el próximo martes, van a poderla ver.
Van a poderla ver. Decía yo, a partir de 12 horas, en este momento no van a poder entrar a verla en el pregrabado, pero mañana en la mañana ya van a poder entrar y toda la semana hasta que llegue nuestra segunda sesión van a poder vernos de nuevo desde el minuto 1, desde el minuto 0 hasta el final para que repasemos todos los datos que nos ha dado la doctora Karina Venter y por supuesto lo que hemos conversado aquí en esta parte final de la sesión de hoy. Recuerden que contamos con el aval y los puntos de certificación por Compedia. Para eso tienen que asistir a 3 de las 4 sesiones y al final la plataforma tendrá también una evaluación para que completen y obtengan sus puntos de certificación. Ha sido un gran placer compartir con excelentes profesionales en el día de hoy. Estamos felices, contentos de que más de 2.000 colegas y amigos en toda Latinoamérica se hayan conectado a esta primera sesión y nos seguiremos viendo durante las próximas semanas para conversar más sobre lo que significa el problema clínico de la alergia a las proteínas de leche de vaca. Próxima sesión, a esta misma hora, el siguiente martes, y vamos a tener 2 invitados de lujo para conversar sobre la perspectiva del manejo nutricional, cómo ha cambiado el manejo nutricional, qué viene sobre el manejo nutricional y por supuesto vamos a tener la oportunidad de responder más preguntas de lo que hemos visto hoy sobre los tiempos, la forma, cómo vamos a hacer ese tratamiento. Así que muchas gracias y en nombre del equipo de Compedia, en nombre de todo el equipo de Abbott, muchísimas gracias por estar por nosotros, por conectarse y les mandamos un abrazo virtual. Hasta la próxima sesión.